Good afternoon, everybody. Thank you, Melissa, for again being willing to join us. Looks like you're from your usual setting in your kitchen as opposed to your office. As many of you know, Melissa is with CMS, and she's joined us from time to time to update us on what's going on at CMS, particularly with respect to the settings rule. For those who haven't joined one of our calls, Melissa is the Deputy Director of the Disabled and Elderly Health Programs Group at CMS, and she has over 25 years with the agency. So it really is our privilege to have her speak to us today. Melissa's going to start by updating us, and then we'll have time for questions. I know some have submitted questions already. Others you can submit in the chat. So Melissa, so we don't take up any more time, why don't you go ahead and update us on what's going on?
Thank you so much. You know, the life of someone working at home, I'm joined by my daily coworker, my dog Izzy, who decided that right now she's starving. So apologies for that. I should also tell you that my landline has rung about 4 times already today with telemarketers. So I am sure it will ring at least once on this phone call. So appreciate everyone's patience. So if I am remembering correctly, we last spoke in October of 2020. And we have now almost another full year of the public health emergency under our belt. I'm glad that I didn't know then that I would be saying this to you today, but here we are. And so before we jump into the HCBS settings rule details, I wanted to give you a quick look at the landscape in which Medicaid is operating. Whether you are receiving services or a family member of someone who is receiving services, or you're a provider delivering services, you know that the public health emergency has disrupted a lot of life. CMS and our state partners are engaged in so many COVID relief activities to facilitate services being available as nimbly as possible. States are doing things like altering the array of services available temporarily, altering the scope of providers who are authorized to deliver services, altering the payment mechanism for those providers to make up for decreased business. And so that work is continuing on a daily basis as we try to patch holes, where they are revealing themselves. A key relief valve, so to speak, is the American Rescue Plan, which authorizes some additional federal dollars for home and community-based services between April 2021 and March 2022. So as states are providing the types of home and community-based services that the American Rescue Plan describes, they will get enhanced federal matching funds for the provision of those services. And the state is then expected to use those enhanced dollars to implement activities that, quote, expand, enhance, or strengthen Medicaid-funded home and community-based services. States are determining how to spend those extra dollars, within the parameters of the statute and within the parameters of guidance that CMS issued for implementing the provision. But we are excited about the possibilities there. But that's just one example of some COVID relief activities that are taking up a lot of time at both the state and the federal levels. And as backdrop to all of this, we have the settings rule. Suffice it to say that 2020 and so far in 2021 have not gone as planned in terms of states being able to implement the activities they thought they would be doing to assess providers against the settings criteria, to determine which providers are presumptively institutional, which we'll get into in a minute, But the regulation remains top of mind. One thing that has not changed with the public health emergency is the priority that CMS gives the settings regulation and the commitment that we have to ensuring that the settings regulation is implemented with fidelity. It remains a pivotal tool in ensuring that home and community-based services are furthering the tenets of autonomy and independence and individualized goals and preferences. The person-centered planning specifications in the rule are sound. They don't presume to make decisions for beneficiaries. They are to ensure that the beneficiary and those family and friends he or she wants at the table are given the opportunities to make their own decisions. So, let's talk about implementation strategies associated with the regulation for a minute. It's important to reiterate the framework that goes along with any Medicaid regulation. The provisions that you see issued by CMS and that appear in the Code of Federal Regulations are federal requirements. States have to meet those. As the other funder of Medicaid services, and therefore the other decision maker in the Medicaid program, states can choose whether to implement those federal requirements as they are, or whether to add to them. And so this means that states can add criteria of a home and community-based setting beyond what's in the federal regulation. And to seg into heightened scrutiny territory for just a minute, and we'll certainly come back to it, states can also add criteria to what constitutes a, quote, isolating setting. So Ashley was kind enough to forward me some of the questions that were on your minds. And I can see that several of them are variations on the theme of decisions that a particular state is making as they implement the rule. Maybe in terms of size specifications for a setting, or the types of providers that the state wants to remain in its home and community-based services provider array. And your questions of me were whether those decisions comport with the federal settings regulation. My answer to that is that states have to meet the federal specifications, but again, they can exceed that criteria at their discretion. So it is always equally important to understand what's coming federally in terms of requirements and provisions, and understanding what's coming from the state in terms of any additional specifications that might layer on top of the federal requirements. And states know that CMS is supportive of their implementation approaches as long as the federal requirements are met, and as I'll get into in a minute, as long as the states are making sure that the system for home and community-based services is going to meet the needs of Medicaid beneficiaries in their state who have HCBS service and support needs. So one caution that I would give you is to really confirm with the state directly that your understanding of a particular state level requirement is correct. It is so easy to have misinformation take root and become common understanding in a way that's not really reality. We've had assertions made to us that this state is implementing this requirement, and when we go back to the states, that's not totally accurate. The state can sometimes track where that misunderstanding happened, and sometimes they can't. But just as it's critical to understand directly from CMS what's in the federal reg and what is behind the federal implementation expectations of the settings rule, it's just as important to understand exactly from the state directly what they are adding on to the reg, if anything, and what their implementation approach is. We have asked states, to the extent they are adding on to what's in the federal reg, to kind of own those decisions and say the state is choosing to implement this requirement above and beyond the federal expectation. We do hear with some frequency that the CMS role in a particular provision is always out front. You might be hearing from a state that CMS requires the state to do this, or CMS prohibits a state to do that. And we're used to that. You can certainly confirm with me whether a particular provision or prohibition or requirement is or is not in the federal settings rule. But you will also hear from me and from my colleagues that you also need to understand what the state's implementation approach is as well. But once you do understand or solidify that your understanding of a state requirement is correct, understand that as long as the state is meeting the federal requirements of the regulation, they do retain the authority to implement their own additional requirements. The flip side of that is that states have the responsibility, both now, today, and after the transition period associated with the settings criteria expires, to make sure that the system that they are implementing is there to meet the needs of individuals in their state who are on Medicaid and have the home and community-based services and support needs. So if you've got questions in that regard, then you should feel free to ask those questions of the state. So let's talk about heightened scrutiny. Heightened scrutiny is always the top of mind. So I will sound like a broken record to those of you who have heard me speak before, but I do like to be consistent. Heightened scrutiny is a part of the regulation and it's not going anywhere. But rather than wondering about or worrying about whether a particular setting will require a heightened scrutiny review, your efforts are much better spent or much better placed in ensuring that that particular setting adheres to the regulatory criteria. That is the focus. That should be your focus because that is our focus under a heightened scrutiny review or as part of a heightened scrutiny review. The whole purpose of heightened scrutiny is to make sure that a setting that meets any of the three categories of a quote presumptively institutional setting really does meet the reg. So we are evaluating that setting against the same regulatory criteria that all settings have to meet. So demonstrating to the state that you either meet the rules criteria or you will by the end of the transition period with any needed changes is what you need to do. And then the state needs to send that documentation to us so we can verify that. So I'll remind you of the guidance that we issued in the form of frequently asked questions in March of 2019. That guidance is still in effect. It's on the Medicaid.gov website. And you'll certainly be notified if we issue any updated guidance. The 2019 guidance defines for federal purposes the criteria of an isolating setting. States can add to that again, but that's the federal criteria of an isolating setting. And I'm going to kind of reiterate what those are, because I think sometimes there's still, it's easy to kind of lose the context for what an isolating setting really means when you see that word pop up several times in the regulation and in some other conversations. So what does CMS mean when we talk about a setting that is isolating to HCBS beneficiaries? As we said in the guidance in March of 2019, there are a couple of factors. There are 3 bullet points that define an isolating setting, and they are due to the design or model of service provision in the setting, individuals have limited, if any, opportunities for interaction in and with the broader community, including with individuals not receiving Medicaid-funded HCBS. That's the first bullet. The second is the setting restricts beneficiary choice to receive services or to engage in activities outside of the setting. And the third bullet is the setting is physically located separate and apart from the broader community and does not facilitate beneficiary opportunity to access the broader community and participate in community services consistent with the beneficiary's person-centered service plan. So I hope that there is a recognition that a setting that sees itself in that criteria of isolation understands that that setting is not compliant with the regulation. There are so many criteria in the regulation that talk about how a setting needs to facilitate beneficiary access to the larger community. That doesn't mean that people are expected to engage in their community all at once or all in the same way, but it is designed to give people opportunities. You heard that word a couple of times in the wording of the letter. And so that's what we mean when we say isolating. If a provider meets the criteria of an isolating setting, then the provider has work to do to comply with the regulatory criteria. There are no two ways around that. But that's regardless of the heightened scrutiny requirement. That provider would need to make changes to its way of service delivery just to comply with the regulation by the end of the transition period, or that provider would need to stop the receipt of Medicaid funding for home and community-based services. So again, in so many conversations with so many stakeholders in so many states, heightened scrutiny is the topic that just attracts so much attention in a way that I think pulls attention away from where it should be focused, which is on making sure each setting complies with the regulatory criteria of a home and community-based setting. So certainly our goal is to ensure that as many providers as possible comply with the regulatory criteria by the end of the transition period and continue being able to furnish Medicaid-funded home and community-based services. And that compliance with the regulation would not just be on paper, but in practice as well. And that's not so beneficiaries receiving services all live the same experience. It's actually just the opposite. It's so beneficiaries receiving services in that setting through their own receipt of services and through the assistance, again, of the friends and family who that beneficiary wants to assist them, can decide how they want to live. Those decisions are not being made for them by virtue of where they are receiving services. And a reminder, you've heard me mention the transition period a couple of times. It is running through the end of March 2023, so roughly a year and a half from now. And throughout the transition period, providers can still be receiving reimbursement for Medicaid-funded home and community-based services. That's one of the protections of the transition period. It means that CMS still reimburses the state for home and community-based services provided to beneficiaries who are in settings that today are not compliant with the regulation. And that protection will last until the transition period expires, which is March of 2023. So let me wrap up this part of our hour together with a couple of acknowledgments. I know, and we all know, that there are individuals receiving home and community-based services who have severe disabilities and who need a lot of services and a lot of supports. I know that some of you listening to me are advocating for people you love and have been doing so maybe for decades. I want you to know that I am not putting myself in your shoes because I can't do that. Nothing about the settings rule is meant to enforce a particular integration mandate or have a one-size-fits-all expectation. The person-centered service plan and the person-centered provisions of the settings rule should act as the compass, if you will, reflecting what each person needs to live his or her own life according to their own circumstances, but also according to their goals and preferences. And I dare say that's what most of us want, is to be informed by, but not defined by, our circumstances. I'd like to, before I open it up for questions, I'd like to to hopefully reserve the last 10 minutes of this hour, 10 minutes or so, to take advantage of having you all together to discuss a COVID-related issue. And that is the rollout of vaccines, either the initial doses or the boosters. We know that boosters are now recommended for older adults and individuals at high risk of acquiring COVID. And we all recognize that individuals receiving Medicaid funded home and community-based services could very well fall into either or both of those categories. And so I'd like to discuss what worked from your perspectives in administering the initial round of vaccines, what challenges you experienced in rolling out those vaccines, and what questions you might have of CMS and states. But before we do that, let me stop and give you an opportunity to ask me questions about the settings rule.
Thank you very much, Melissa. As always, it's very informative to hear from you. And I guess I would also add that if the 50 states applied the settings rule with the empathy and compassion that you show, we would not have a problem. And I think, at least in the words you express, you indicate a degree of flexibility on the part of CMS, which is very important and very desirable. We are not seeing that at the state level. And, you know, I don't want to attribute ill motives to anybody. I think it's simply a matter of when you're a state regulator, a state bureaucrat, and you're charged with making sure your state is in compliance, it is far easier to have a one-size-fits-all type of solution, because that you can administer. You know, what you are talking about and what really needs to happen and what's embedded in the settings rule is an individual, by individual view of things. Is the individual getting the services he or she wants and needs? And are they being served in the setting that they desire? And that should be what it is. But you can imagine that if you're in a state that has 20,000 Medicaid beneficiaries, like Illinois does, for example, to do that on an individual basis gets to be hard. And which doesn't mean it shouldn't be done, it should. But if you're a mid-level bureaucrat in Illinois and you're charged with making sure Illinois satisfies the settings rule, it's so much easier to say, look, I'm not going to approve any setting that has more than 4 people in it, or whatever, or, you know, you got to not have homes next to each other, or, you know, whatever the criteria is, just so they can administer in some relatively easy way the rule. And that's where I think the problem comes up. So that's just my editorializing and maybe providing you with information. I think I've made the speech to you before, so it's probably nothing new to you. Let me start out, since I'm moderating this, with taking the privilege of asking a couple of the initial questions. First of all, just very quickly, since the pandemic is continuing and the emergency situation is continuing, do you envision a further extension of the deadlines?
That's a very valid question, and we get it from other stakeholders as well, and we have been talking about that internally. So I'll couch this by saying this is my response on the 22nd of September, 2021. I think we have all found that we make assumptions about where we're all going to be in our professional and personal lives a few months down the road. And then that doesn't necessarily come to pass. But we are hopeful that we will not need to extend the transition period. We certainly would prefer not to. certainly we are realistic in, we use our own lives at the federal level as a proxy for what we imagine our state colleagues are living on a daily basis. And I would say that at least 50% of my own life day to day is spent on COVID activities. And then the rest of the time is spent on non-COVID activities, but they are still impacted and influenced by the fact that we are still sitting in a public health emergency. And so it is our real goal to not extend the transition period any longer. But we are certainly still keeping an eye on what states are able to do, what they're not able to do. Certainly, we don't expect them to be traveling on site to do on-site assessments of particular settings. And that raises disadvantages, certainly. I mentioned that the activity states assumed they would be doing in 2020 and so far this year have just not come to pass. Not only have they needed to focus their resources on COVID relief, but it certainly was not wise to be traveling and to be face-to-face with providers and staff and beneficiaries. And so when we will be in a spot where that travel is routine business travel is kind of back up and running, I think we'll all find out together. And so we have to take that into account in how we go forward relative to the current end of the transition period. But it's really our goal at this point to not extend it. And I would also keep you posted if that changes.
Yeah, Melissa, thanks for that. I would also point out, I mean, you make reference to regulators being able to travel. It seems to me that in the current environment, to expect a lot of community involvement by the beneficiaries when there's high transmission of COVID obviously doesn't make sense. And I'm sure CMS isn't saying, hey, yeah, you need to get out anyways. Who cares about the risk of disease? So I just don't know how you judge in the current environment the community opportunities when they have to be restricted by the virus.
That's entirely correct. And CMS does not expect beneficiaries to be experiencing their community, in a way that is not that is counter to the public health guidance that's coming out from the experts. I mean, certainly I have not seen the inside of my office in the CMS building since March 13th, 2020. And, even this far in, my non-work activities are very, very, very limited. And so I would expect that to be the same for Medicaid beneficiaries. And so that also is a reality that even if a state employee were able to travel to an HCBS provider to do an evaluation, what they would see is, chances are, beneficiaries being at home, receiving services maybe remotely through telehealth in a way that they otherwise, would not be doing. And so now is not the time to be judging how a setting facilitates community integration of
I just don't know if that message is getting heard by the states, because I'm certainly aware of states trying to make that sort of assessment in real time. And that really puts, I think, providers in a very difficult spot if they're being assessed in the current environment. And I don't want to take up all our time on that issue, but I just think it's important that you be aware that I think is a very problematic situation.
And it may be that the states are kind of bifurcating what they can do from a desk review, from their own homes or from their offices, and what really requires an on-site review. And so they might be able to make some progress in some areas. But I, from what we understand in our pretty routine conversations with states, I think most, if not all of them, still are not traveling with any kind of regularity. And so I would imagine that what they're doing is limited to a paper review, which has some merit, but has some limitations as well. And so so I think we all kind of recognize that as the reality, and that will need to be taken into account as we move forward with what happens with the transition period, what we realistically can expect states to have accomplished between now and then, what our own life looks like in terms of our ability to do federally based site visits. So there remain a lot of variables that I can't and you can't, say today, how they will play out. The goal is to keep each other, kind of posted as decisions are getting made.
Sure. What I'd like to turn to now is a letter that Congressman Fitzpatrick from Pennsylvania sent you and the CMS's response. And I want to focus on one of the questions and the CMS answer. And so I don't know if you have those in front of you, Melissa, but let me, for at least everybody that's on this Zoom, I want to read the question, and it's a pretty involved question, and then we read your response, and I want to sort of try to dig a little bit deeper. The question is number 4 in Congressman Fitzpatrick's letter, and it deals with the issue that you touched on a bit in your remarks about what is an isolating setting. And I understand you're saying, let's focus just on whether the setting is compliant or not, but as you point out, the settings rule does use the word isolating, and it is, for some settings, the determinant of whether a setting is under heightened scrutiny or not, right? Because that's what the rule says.
Right.
You're under heightened scrutiny if you are isolating. And so the question is, what is isolating? And your guidance in 2019 attempts to define that. And another warranty call.
You know what? This was on my CMS iPhone. Chances are it was exactly a warranty call. I would place money on it, actually, Scott.
So Congressman Fitzpatrick does a pretty good job in his question 4 of sort of summarizing your 3 bullet points in your guidance. And what he says is, is a place not isolating if it meets these 4 criteria, right? And it says, 1, the setting offers individuals it serves opportunities to receive services and engage in activities in the broader community, and offers to provide the supports each individual needs to access those services and activities. 2, individuals then choose whether to receive services and engage in activities in the community or at the setting. 3, the setting honors those choices. And finally, 4, all this is documented in the individual's personal plan. Now, CMS's response to that question was as follows. In your letter, you outlined 4 characteristics of home and community-based settings. However, those will not alone meet all the settings criteria outlined in the regulation. The state must assess each setting to determine that all of the settings criteria are met in order for a setting that meets the characteristics of isolation to overcome its institutional presumption. Now, my point is, I believe I read your answer as begging the question. The question was, if a setting has these 4 characteristics, is it not isolating? And if your answer is, well, there may be other things, we need to know what those other things are, because we think that Congressman Fitzpatrick has accurately summarized your 3 bullets, as well as the settings rule. And it's not saying, does this meet all the requirements of the settings rule? It's just saying, is the setting not isolating and therefore not subject to heightened scrutiny if it meets those 4 criteria?
So I appreciate the opportunity to clarify. So the response, what the response was saying is that there's two components to how a question is answered with regard to any kind of setting. One is whether it is going to require heightened scrutiny, and one is whether it's compliant with the settings criteria. And so the way we read the incoming question from Congressman Fitzpatrick was to say, if a setting met these four components, is it compliant with the regulation? And so we had to answer it with well, that doesn't touch on every single criteria in the reg. Now, what that narrative in the incoming letter said to us was that it's a good paraphrasing, and paraphrasing is an important word. Paraphrasing of a way to ensure that setting does not meet the isolation criteria in our March 2019 FAQs. It's not to say CMS is giving a setting that meets those bullets in the Fitzpatrick letter a firm no, that setting is not isolating. We would need to take a look at every setting. But it's a good start. What's laid out in that letter.
But again, this is so important, because again, this is an issue that we're wrestling with each of the states. And so if CMS is saying, well, that's a pretty good start, but there may be other stuff. Well, what other stuff? Now, again, I'm not asking about, do they meet all the requirements of the settings rule? Because this doesn't talk about, are there locks on doors? Is food available? Those aren't isolating criteria, right? Those are other things that the settings rule requires. I'm just focusing on whether a setting is isolating, which is what the question asked, and therefore subject to heightened scrutiny. Now, I believe, unless you can point to me to something else, that if a setting meets those four things that Congressman Fitzpatrick has outlined, it is not isolating under the CMS guidance and the rule, and therefore not subject to heightened scrutiny. Now, again, there may be other things the setting has to do to meet the settings rule. There has to be person-centered planning. There has to be locks on doors, blah, 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 blah. I'm just talking about the isolating component under the heightened scrutiny. And I haven't heard you say, oh, there's some other thing that a setting has to do so it's not isolating, even if it meets all of those things in the Fitzpatrick question.
So let me clarify. And I could hear myself when I was saying they're off to a good start, thinking that that's not going to be an acceptable response. So I'm glad you're giving me an answer to or an opportunity to clarify. So what I would need to do, and at this moment is probably not in the right moment, is literally do a side-by-side of our isolating criteria in the 2019 FAQs and what the Fitzpatrick letter says, in terms of couching that in the positive. What our isolating criteria says is, this is a negative outcome in terms of beneficiary experiences. What the Fitzpatrick letter does is recouch that to say, oh no, well, what if the setting does facilitate, A, B, and C? What I need to do is evaluate those two narratives up against each other. What I will say is the language that was in the Fitzpatrick letter sounded like that individuals would have opportunities for community integration facilitated. There was a reference to person-centered planning. That's all good. There is a good likelihood that a setting that came to us under heightened scrutiny that said, here's how I as the state have documented that the setting meets all of the tenets that were in the Fitzpatrick letter. There's a good likelihood that we would say that is not an isolating setting. Can I give you a yes or no answer, which I know you're wanting? I'm not prepared to do that, because I would literally need to compare the two.
I would ask that you please do that. And again, the reason why this is so important is, as you know, states right now have to go through all their settings and determine which ones need to be subject to heightened scrutiny. And most of the settings they're looking at are not ones that, are located in a public institution or, the first two criteria. It's all being judged under, is it isolating?
Mm-hmm.
And states are wrestling with that. And so I think this question is really important. I think states need to know if a setting does all these things that Congressman Fitzpatrick has pointed out, isn't it not isolating and therefore not subject to heightened scrutiny? And if CMS thinks, no, there's something else a setting needs to do, we need to know that. The states need to know that.
Well, let me clarify that that any setting, any presumptively institutional setting that comes to CMS under heightened scrutiny review will be evaluated against the regulatory criteria. You see that listed in the 2019 FAQs. There's some pretty explicit language that talks about the types of information that the state should submit to CMS to facilitate our heightened scrutiny review. And you can track all of that information back to a criteria of the regulation. So there's not a secret test, if you will, that we are applying to a presumptively institutional setting.
But again, I'm not focusing on what CMS does once a state's determined that a setting is under heightened scrutiny and now is trying to overcome that that scrutiny. The initial issue is, should a state consider a setting isolating and therefore subject to heightened scrutiny? That's the process that's going on right now. Before it even comes to CMS, states need clear guidance on what's considered isolating. I think your 2019 guidance provides that. I think Congressman Fitzpatrick did a good job summarizing it. And yet we get a non-answer from CMS. We get an answer that says, well, there might be some other stuff, without telling us what that other stuff is. I can't see what that other stuff is, because again, while there are other requirements in the settings rule, they have nothing to do with isolation. They have to do with other aspects of the rule. So states and the public need to know if what Congressman Fitzpatrick hasn't outlined isn't enough, what's the other stuff in determining whether a place is isolating and therefore subject to heightened scrutiny? Because if it's not subject to heightened scrutiny, it never comes before CMS, and that's fine. Again, assuming all the other stuff is met in the settings rule.
This is my landline. So Ashley, I know you had included a link to the CMS response to the Fitzpatrick letter. Do you have the actual incoming letter? Excuse me, handy.
I've got it in front of me.
Yes. I posted the link to the website that actually has the both
okay.
questions and response letter.
Yes. Thank you.
And again, I'm putting you on the spot. I recognize that. And you don't need to answer it this afternoon, but I think everybody would benefit from a clear answer to that particular question. I think the CMS did a great job answering the other questions, and people found that very informative. But my view is that question you guys punted on and really didn't answer what was being asked. So,
may I ask a question? Am I
sure,
allowed?
Go ahead, Elizabeth. Yeah.
Well, I know I came in late, so pardon me if I've messed up and you've already said this, but he says in his
Elizabeth, we only have 3 minutes. So if you could follow up with us in an email, that would be great, because we need to wrap it up and leave the next 10 minutes for. Sorry about that. Go ahead, Scott.
Let me just also ask you, Melissa, because a lot of people are interested in knowing, when you're looking at a non-residential setting, let's say a setting that is providing recreational services for Medicaid folks. And let's say that facility gives individuals choice. You can do this activity in the community, or you can do some other activity in the setting. The individual makes those choices. It's all documented in a personal plan. what else does a recreational facility need to do in order to avoid heightened scrutiny and in order to make sure it's meeting the settings rule?
Mhm. So if I were operating that setting, I would be in conversation with my state Medicaid agency to say, here is how I am meeting the criteria, the regulatory criteria of the settings rule. And again, that's where I would hope my energy would lie. The state is the one that needs to determine what settings are coming to CMS for a heightened scrutiny review. What of their universe of settings falls into any of the three categories of presumptively institutional. Totally agree with you that the isolating category is the one that requires the most analysis. But I, as an operator of a setting, need to justify to a state, whether heightened scrutiny is in my future or not, how I am meeting the settings rule. The state, each of the criteria of the settings rule. If the state says to me, I think you are isolating as I compare your method of service provision or method of operations against the isolation criteria in the CMS FAQs, then I might say, here's how I would justify or document that I don't meet that criteria. But again, you know, the main point is to say, here's how I meet the settings criteria.
Well,
If the state has a question about how to apply the isolation criteria to determine whether a specific setting is presumptively institutional, we're in the business quite frequently of having those conversations with the state to say, tell us what you're seeing, tell us what your process is for making a determination about whether a setting is presumptively institutional and needs to come to us. And we provide that level of technical assistance. But again, the goal, if you are a provider of services, if you can justify how you meet the settings criteria, it doesn't matter if heightened scrutiny is in your future or not. That is kind of an extra step that you might have to go to based on the state's assessment. But if you can justify that you are meeting the settings criteria, heightened scrutiny should not be a problem for you. Whereas if the state is saying, I see you meeting this criteria of isolation, chances are that means your bigger problem is how you meet the regulation, not how you determine that you don't meet
in many cases, it's all about whether a setting is isolating. And this is, again, particularly true in a non-residential circumstance where you're not worrying about locks on doors or the other things that clearly are only for residential settings. It comes down to so-called community involvement. And again, if that setting is saying, look, we're giving everybody choices. We have a menu of activities, some of which are in the community, some of which are at the setting. Each individual makes those choices. We facilitate those choices. We document those choices. Mm-hmm. What else does a recreational setting, a non-residential setting, need to show they are not isolating?
I don't know whether I'm going to be able to give you a satisfactory answer here, because the component that's missing from this conversation is, again, the state. I, as CMS, am not assessing a particular setting against the federal criteria. The state is, and the state might say, here's how I'm interpreting the CMS criteria. And P.S., here's whether I'm adding on to that criteria of isolation with some state-specific criteria. So the provider, we certainly, try to demystify what is and is not in the federal reg. But anytime we're having a conversation with a provider, we say, you've got to circle back with your state to understand how they're interpreting the federal reg and whether they have their own additional criteria. And so it's that provider state dialogue that CMS is not generally a part of that is equally critical. And so asking me if a particular setting or a setting that looks a particular way is compliant with the federal rule, I might be able to give you, an answer that's, fairly like, well, it seems like it's, I can't find a problem with how it relates to the federal rule. It doesn't mean that the state is going to come to the same determination, or the state's not going to require you to adhere to additional criteria. So that's why I'm dancing around this issue. So now I'm just kind of laying out, straightforwardly that the state's got to be part of that conversation, because they're always the missing third link.
Let me ask you hopefully a very quick question, then get on to the COVID vaccination issue.
Mm-hmm, mm-hmm.
How does one determine if one's living in a private residence, which is one of the factors that you look at in your guidance, because a private residence then is presumptively compliant, and so there's an issue of what constitutes a private residence.
So the private residence shows up in two ways. A private setting that is on the grounds of an institution is not presumptively institutional, versus a public setting that's on the grounds of an institution is. And then if someone is living in his or her own home, that's kind of presumed to not be presumptively institutional.
Right. That's the category I'm talking about. How do you define one's own home?
I think I'm a little bit rusty on this. I want to say we might have an FAQ on this on the CMS website. So if you go there and I go there, we'll try to find it. It also could mean that they are living in a home in which they are paying rent or have a mortgage, or they're living with a friend or family member who is not a service provider to them, but that they're living with someone who, pays the rent, pays the mortgage. But I am a little hesitant to go any further without kind of refreshing myself to what we've said. But that is certainly a relevant question, and we are happy to have that kind of conversation, with you, your members, with states, to make sure that that everyone's kind of on the same page about that.
Right. Okay. So I know I didn't give you exactly 10 minutes, but go ahead with your COVID vaccine.
You're a tough cookie, Scott, but I expect nothing less from you. So, this is not a once and done conversation, because, clearly we will be in this business for a bit on the settings rule and on COVID vaccines. So we learned together on Friday that that COVID boosters are recommended for older adults and people who are at higher risk of COVID and a severe reaction to COVID. Whether or not that universe will be expanded, is not up to CMS, and we will again, find that out together. So this is obviously not our first go around in administering COVID vaccines, and some individuals we know are not yet vaccinated, and so it wouldn't be a booster that they'd be getting, but they might be newly applying for or receiving the initial doses of the COVID vaccine. So what we're interested in, how to make sure people in all sorts of settings, be they group homes, assisted living, intentional communities, what have you, are not lost in all of these rollout activities. On the one hand, it's a very there's a very direct relationship between the federal government and nursing homes, hospitals, intermediate care facilities for individuals with IDDD. It's not a direct relationship between the federal government and a group home, because you've got the state, as in that intervening spot. And so how to make sure that, people who are in these higher risk categories of our HCBS population are on the radar screen of states. We are having these conversations with states. We're having these conversations with CDC. CDC has some information on their website that is probably going to be updated as soon as in the next couple of days for both individuals who are receiving services and individuals who are the administrators or managers of like a congregate setting. What might be new information is that group homes, assisted living, et cetera, are now eligible to participate in the pharmacy partnership program, which might mean that pharmacists actually come on site to a group home and administer either initial vaccines or boosters to all of the residents at once. We're also encouraging states to take advantage of non-residential settings, day programs, for example, to serve as kind of a hub or be, kind of temporarily looked at as a vaccine clinic, where again, people might be able to come into the site and receive their COVID vaccines directly from, again, pharmacists who might temporarily be there to administer the vaccines. So my purpose for bringing this up is twofold. One, to make sure you all were aware that these conversations were happening at the federal and state level, that there has been now an opening up of home and community-based services to participate directly in the community pharmacy partnership, but also to solicit your own good experiences with the rollout of the initial vaccine, challenges with the initial rollout, any gaps you think CMS or some other federal partner could fill as we continue to be in the business of effectuating vaccine rollout. So, we're in the last minute of our time together. And do I have a 5 o'clock meeting? Yes, I do. But so I'm going to have to jump off, but you've got steady access to me to communicate this information through Ashley, through Scott. And we do want to take advantage of having you all here to lay out these questions for you. Hopefully we can take advantage of efficiencies and lessons learned from the last go around to make this second foray into vaccine administration go a little smoother. So I invite you to submit to me any feedback that you want us to be aware of. In the meantime, do keep in mind and visit fairly frequently the CDC websites. We will all be hearing from FDA and CDC on whether boosters are recommended for a broader population, and then we'll go from there. So great. I know we're at time. I know we could have spoken for another 5 hours. And I know this is the last thing I'll leave you with is that I understand fully that this is not an academic conversation. This is real life. This impacts people you love. And this is a key regulation from a CMS perspective to make sure is implemented with fidelity and in a way that causes the least amount of disruption and maximizes individuals being able to exercise as much autonomy as they can. So we will continue to be in touch, and you can continue to use me as a conduit for other information, including outside of the settings, right?
Great. Thank you so much, Melissa. Thanks for your time.
Thank you so much. Good night.
Yeah.